Good morning to everyone present here. Today's case is about a 35-year-old male. Uh, First of all, I would like to thank everyone for providing us this opportunity to present this rare case. So today's case is about a 35-year-old male who presented with a reddish inflammation on the skin, and subsequently with all the differential diagnosis and different possibilities in our mind, we finally concluded that it was cancer in cuirass, which in itself is so rare that mostly if we search, there are only case reports, following which the primary was established to be breast cancer. So breast cancer in a 35-year-old male again is a relatively rare entity. And what makes this case more interesting was
you should not tell everything in upfront. This is how you build a case. Just
okay.
So it's correct.
Good morning, everyone. Good morning, everyone. So I'm Dr. Mayank, senior resident in the Department of Medical Oncology, and today I'll be presenting the student CPC under the guidance of Amit sir. And Ridul sir, Dr. Shranav and Dr. Kashvi will be dealing with the pathology and the nuclear medicine part of my discussion. So what are the specific learning objectives? First of all, how to approach a case of carcinoma and cuirassive, that is a cancer of unknown primary, differential diagnosis associated and the associated dilemmas, and how do we manage such cases. So coming to the demographic profile of the patient is Mr. X, 35 years old male. He's a graduate with a lower middle socioeconomic status. He's a resident of Haridwar. So he just had the complaints of painless skin thickening over the left chest and neck, which was progressive over the past 1 year. The thickening was associated with slight itching, and initially it was just involving his chest, and gradually it progressed to involve his whole left side of the neck, leading to torticollis also. For this complaint, he visited multiple facilities and received antihistaminics, topical creams, and there was no relief in symptoms, and the skin thickening gradually kept on progressing. There was no history of any associated fever, any history of pain, allergies, rhinitis, no history suggestive of Raynaud's, no history of dysphagia, difficulty opening mouth, or any similar thickening noticed elsewhere, and no history of any prior trauma, although there was a significant history of loss of appetite and weight loss. Past history, there was no history of any diabetes, mellitus, hypertension, tuberculosis, or any thyroid disorders, and family history was not suggestive of any similar complaints in the family. No history of any malignancy in the family, no history of any CAD or any TB contact. Then on examination, the patient was conscious, cooperative, and well-oriented to time, place, and person with a GCS of 15/15. His ECOG performance status was 2. Build was fair. There was no pallor, icterus, cyanosis, or clubbing. On the lymph node examination, importantly, the left cervical, that is level 1 to level 4 lymph nodes, were enlarged of the size 3 by 3 centimeter. The central and anterior axillary lymph nodes were enlarged of the size 4 by 5 centimeter. Left inguinal lymph nodes 1 by 5 into 1 by 5 centimeter, and all the nodes were characteristically matted, non-tender, immobile, irregular, had an irregular surface and hard consistency. Vitally, the patient was stable. Then on local examination, the skin over the left hemithorax was visibly thickened with slight redness. On palpation, it was non-tender without any local rise of temperature. The patient also had stiffness of the left side of the neck because of the skin thickening. Bilateral breast examination was done. It was normal with no lump palpated. The rest of CVS, respiratory system, and the per abdomen system examination was within normal limits. Sadly, the patient's baseline picture was misplaced, so this is just a picture of the picture similar to the picture the patient had presented to us. So to summarize, 35-year-old male with gradual onset progressive skin thickening over the left side of chest with loss of appetite and weight loss, and examination suggestive of painless skin induration, palpable, matted, hard, immobile, non-tender, axillary, cervical, and inguinal lymphadenopathy. So at this point of time, I would like to ask what are the possible differential diagnoses on the basis of this history and examination, if anyone would like to.
Yeah. A medical on more area.
The residents who are here.
Come to DICE and give the difference.
Thank you, sir. 35-year-old male presenting with the skin induration on the left hemithorax. Is slightly this thing I would like to think of sarcomas or lymphosarcomas or lymphomas with a cutaneous presentation, sir. Differential diagnosis. And apart from that, neurofibromatosis also can present like this, sir. This thing.
Why malignancy only? Most common cause of inflammatory skin changes are not malignancy.
Sir, inflammatory, like I would think, and if it was inflammatory, the patient would be in painful condition, sir. It's more of a painless, and it is presenting for a longer duration of symptomatic duration is very longer period. So I would like to think of non-inflammatory causes, sir.
Okay, so we are talking about differential. So, as Dr. Amit asked, what will be painful causes?
If you are working medical oncology, that doesn't mean every patient is malignant.
Since the patient had no signs of any Raynaud's vein or this thing, if it was present, we could have thought of scleroderma and systemic sclerosis. That can also present with this thing. Usually that is present in the distal extremities and perioral. But atypical presentation can be considered in such cases.
Tuberculosis?
Cutaneous presentation of tuberculosis can also present. Cutaneous.
Point favor, point against.
There was no history of fever or loss of appetite for longer duration of this thing.
Loss of appetite, weight loss तो show किया. Matted lymph nodes हैं आपके. Classical teaching of matted lymph nodes is what?
Tuberculosis.
That's why we say कि never tell the initial diagnosis. That's why we should have a differential. If you get this case in exam, what will be your differentials?
Yes.
Okay. Come on.
Thanks.
Justify.
So, as Dr. Karthik clearly told that we have the possibility of oncological versus non-oncological diagnosis, and so I'll be just firstly enumerating the oncological and non-oncological causes and what are the points which favor oncologic and what are the points which favor non-oncologic. So, oncological causes can be, as Dr. Karthik told, lymphoma, breast cancer, and sarcoma. Non-oncologically, the patient can have scleroderma, contact dermatitis, filariasis, nephrogenic systemic fibrosis, or scleroderma diabetica. So, firstly, why did we consider malignancy first and oncological causes first? The points in favor are the characteristics of the lymph nodes, that is hard, irregular, progressive lymphadenopathy, and the significant history of loss of appetite and the loss of weight. And the points against this are that the patient did not have any apparent primary, and the patient is quite young, a 35-year-old male. We generally don't think of oncological causes as first. Then coming to the non-oncological causes, the first we can consider scleroderma. Points in favor are the skin thickening, but again there was no history of Raynaud's, dysphagia, difficulty in opening the mouth, or any similar thickening noticed elsewhere. And other differential could be contact dermatitis, as the skin thickness and redness was only located over a single area, localized area of the skin. But there was no waxing waning character, no history of any seasonal variation, no history of any allergies, or no history of any rhinitis. Other differential could be filariasis, as there was localized thickened hard swelling of the one side of the skin. But again, there was no limb involvement, no history of fever, no history of any genital involvement. And nephrogenic systemic fibrosis, although can correlate, but there was no history of any gadolinium or any contrast administration to the patient. So, with these differentials, the patient came to us, the routine investigations were done, and core biopsy from the left axillary lymph node was taken. So, firstly, I'd like to call my nuclear medicine colleague to enumerate the PET findings, what we found.
Good morning, respected faculties, seniors, and my colleagues. I will be presenting nuclear medicine findings, PET findings of this patient. So, first of all, maximum intensity projection images of this patient revealed FDG uptake in the bilateral cervical, bilateral axillary, and left inguinofemoral region, apart from physiological tracer uptake in brain, liver, kidneys, testis, and urinary bladder. As we can see here, there is uptake in the bilateral. As we can see, there is uptake in the bilateral cervical region. There is uptake in the axillary region. We can see there is increased uptake here, and there is a focal area of increased uptake on the right axillary region also. And in the inguinofemoral region also, there was seen increased tracer uptake. Focal areas of increased tracer uptake was seen there. And apart from that, there was physiological tracer uptake in rest of the body. Now coming to FDG avid, multiple variable discrete and conglomerated lymph nodes were noted in level left level 1A, 1B, bilateral level 2 to 5, predominantly on the left. Bilateral supraclavicular left interpectoral lymph nodes were noted, with few forming mass-like structures. Few forming mass-like structure in the cervical region, causing significant locoregional and intramuscular infiltration. There was infiltration of parascapular, pectoris major, minor muscles, and upper forearm muscles were also involved. So what we can see here is FDG avid ill-defined nodular lesion noted in the lower outer quadrant of left breast with indistinct fat planes with overlying skin. There was left-sided mild pleural effusion was noted. Apart from that, we can see that there is subcutaneous standing in the skin, probably due to the lymphatic involvement. Lymphovascular infiltration can be there. Now we can see that there was involvement of the axillary lymph nodes. Most of them were conglomerated and were involving the adjacent muscle, with the infiltration of adjacent muscle, and there was involvement of the right-sided axillary lymph node also with increased tracer uptake. And now there is FDG with left-sided external iliac and inguinal nodes were noted, with largest measuring 1.4 by 1.8 centimeter at the left external iliac region. So there was significantly increased tracer uptake in the left external iliac nodes. Now the diagnosis on the basis of PET that was given was, the first diagnosis that came to our mind was lymphoma because of extensive lymphadenopathy on either side of diaphragm because of the involvement of cervical, axillary, interpectoral, external iliac and inguinal nodes. The second differential that was given was male breast carcinoma due to suspicious nodular lesion in the left breast with indistinct fat plane and overlying skin involvement. There were few other subcutaneous nodular lesion and subcutaneous edema, and fat standing was there, likely due to lymphovascular involvement. And the third differential that we gave was soft tissue sarcoma because of extensive parascapular, pectoral, upper arm muscle involvement with locoregional extension and cervical lymphadenopathy.
Is there any relevance of SU max?
Actually, sir, there is relevance of SU max, but we cannot. We were not able to calculate in our system, so we have not given it. But it was 5.7.
Whatever was reported, that is also relevant.
Yes.
So what was SU max from outside?
It was 5.7, sir, in the axillary mass.
Axillary.
Yes, sir.
If we get PET CT in a tuberculosis patient, then what are the findings?
So there will be increased uptake in tuberculosis also. So basically the history will matter, and other thing are that there will be changes in the lymph nodes will also be contiguous lymph nodes will also be active. So it's basically difficult to differentiate between tuberculosis and malignancy on PET CT alone, and histopathological correlation is needed.
So why PV is not a differential? So let's say this was given to you in a exam without any history.
So because of lymph node stations involved all throughout, like there was inguinal lymph node, external iliac lymph node, and then there were cervical and axillary lymph nodes also involved. So many lymph node stations. So probably the first thing that came to our mind was lymphoma only.
What are most common differentials of generalized lymphadenopathy?
So TB can be there.
Glaringly, tuberculosis is missing in from your differential. So the purpose of all these presentations is that it's not that medical oncology is presenting, so everything will be oncology. That's what Dr. Amit also said.
Radiologically, how you differentiate benign versus malignant lymph node, and on PET CT, how you differentiate benign versus malignant lymph node.
So basically on PET CT we will go for SUV max usually. The SUV max greater than 2.5 usually suggests that there is malignant involvement.
Always.
Not always.
What are radiological characteristics of benign lymph node?
So the lymph nodes might be necrotic in some cases.
Aggressive malignancy can have necrosis.
So there will be preserved fatty ileum
That's one difference.
in the benign.
Shape of lymph nodes helps.
Yes, sir. So shape with preserved fatty ileum, being shaped with preserved fatty ileum, elongated nodes. Circular nodes will usually be malignant. Round circular nodes will usually be malignant.
One thing I think I would also like to ask ma'am that any PET characteristics by which we can differentiate these three differentials like lymphoma, carcinoma and sarcoma. Any particular lymph node characteristics apart from the anatomical like pectoral involvement, lymph node involvement, any other PET particular characteristics like SUV max differentiation amongst these three differentials?
The first is that benign versus malignant. Again, we can do a dual point time imaging where in the delayed phase there may be a washout from the inflammatory and infectious lesions. Versus malignancy, they'll always have the retention of the tracer. Then it's difficult to differentiate these individually, but in this case since there was a breast lesion, so it was also considered that there may be two primaries. So with the lymphoma, lymph node involvement, there could be a lymphomatous pattern, and the male the breast cancer lesion was could be considered as a second primary. So sometimes we have the dual malignancies, so that is one thing which could have confused more in this case. And in sarcomas, sarcoma versus lymphoma, since there was a soft tissue lesion, the skin lesion, so it was more again sarcoma. But again, for sarcoma we need to PET CT can help us to differentiate the grading or the aggressiveness of the tumor. So here the SUV was high, it was more than 4, so it was, if it was a sarcoma, it would have been a high grade sarcoma. So that is where the PET CT would have been more helpful. Final diagnosis anyway would have been a histopathology.
Thank you sir and ma'am. So after all these differentials, I'd like my pathology colleague to now comment on the histopath findings.
Why true cut was done?
Sir, actually, ideally we always go for a core excision biopsy in most of the cases. But keeping in mind the location of the lymphadenopathy, generally in the body folds, we mostly avoid the excision biopsy and we go for a true cut.
Why?
Sir, one is the mostly in the axillary folds there is presence of neurovascular bundles also. Possibility of injuring the neurovascular bundles is there, and more of all the cosmetic implications later on are more in those areas. So that's why.
As a pathologist, what is ideal choice in such cases? Are you happy with true cut, FNAC, with side cell block versus excision lymph node?
So we always like to diagnose on an excision biopsy. On a true cut biopsy from a lymph node, it is very difficult to diagnose. But as it was metastatic carcinoma what we diagnosed, so it was easier.
No, what is ideal choice? Like if a pathologist you are asked, what do you like to see? FNAC plus cell block versus true cut versus excision lymph node?
So first choice will be FNAC with cell block.
Ideal.
So that will be our first choice, and then we like to if that comes indeterminate, then we like an excision biopsy.
I'm not asking what is going to be first. What is going to be? If you are given just one choice, what will be your?
So if lymphoma is suspected, it's always excision biopsy, because lymphomas are diagnosed on morphology. On core biopsy or FNAC, we cannot have any morphology, or whether it is effaced or not. For proper diagnosis, we always recommend that if you suspect lymphoma, send us a intact lymph node, that is the excision biopsy. FNAC and other things if suspected metastasis, but for lymphoma, it's always excision intact lymph.
Good morning, everyone. So, we received a core biopsy from left axilla on 19th April 2022, in which we received multiple. So, can you please open slideshow?
Slideshow pointers.
So, in which we received multiple linear gray-white cores ranging from 0.5 to 1 centimeters in length, all embedded as A1, A2. So, on microscopy, on low power, we can appreciate that the tumor cells are infiltrating the fibrocollagenous tissue. This is on low power, and we can also appreciate some focal areas of necrosis. Same thing we can appreciate, the tumor cells are infiltrating the fibrocollagenous tissue. These are the tumor cells which are having large hyperchromatic nuclei. This is on high power, in which we can also appreciate the arrangement of the tumor cells. So here we can appreciate that the tumor cells are arranged in cords, here also in cords, and they are arranged in clusters and in form of ducts also. And they are also lying singly, some of them are lying singly, and they are all infiltrating the fibrocollagenous tissue. These features are actually correlating with the tissue from cells of the breast. So on histomorphological features, the core biopsy from the left axilla showed features of metastatic carcinoma, morphologically compatible with primary from the breast. Further, on immunohistochemistry, pan-CK showed positivity. This micropictograph is showing pan-CK positivity. Also, GCDFP15 was positive, although ER-PR were negative, and mammoglobin was non-contributory. HER2/neu showed positivity of with a score of 3+. Here we can see complete intense membrane positivity of HER2/neu, which is giving it a score of 3+. So, on histomorphological features and immunohistochemical studies, the core biopsy from axilla showed features of metastatic carcinoma from breast. Next.
Are these pictures from the primary tumor? From the same tissue? The pictures of they are from the same tissue.
Sir, these two.
I am telling because morphologically it does not match with the primary tissue that is shown on HND.
Yes, sir. Sir, these histochemical markers, they were positive, and these images of pan-CK and this image of HER2/neu positivity, they are actually representative images, which we have taken to show the positivity pattern. Like it is showing membrane positivity.
So we are showing what HER2/neu looks like.
Yes, sir.
For education.
Yes, sir.
But this picture is not from the same case.
Yes, sir.
Thank you.
So this patient was not positive.
He was positive.
So this patient was positive.
They did not read the HER2. They did not those slides that has faded.
Yes, sir.
Patient slides, they are not sure.
Patient slides, this is not from the patient slide. The HND is from the patient slide.
So these,
is not from the patient slide.
yes, ma'am. Ma'am, these
the staining has faded from that. Picture could not be taken.
But these
Always right if you are taking some other pictures.
Yes,
not
ma'am.
from the case.
Yes, ma'am. So
It should not be written like this.
yes, ma'am. That's why I mentioned that these are some micropictographs which are showing the positivity of pan-CK, and also this HER2/neu is also representative image just for the sake of education. Otherwise, we could not retrieve the slides of HNE of this particular patient. I have put these images just to show how the positivity looks like. But IHC report is like this only of the patient. And further, on 13th May 2000.
Could not be retrieved. This is a relatively new case. April
2022, sir. Last year, sir.
So you don't keep it?
So we do keep it, but we were informed on Friday evening. So we were not able to, and IHC slides couldn't be found. And the tissue on the block was also very less. So HE slides we could get, but the IHC was not there.
So further, on 13th May 2022, we received an FNAC requisition from two sites. Site 1 was from right axilla, which was suboptimal for evaluation due to lack of cellularity, and it was inadequate for any opinion. And site 2 was from left mammary region, which showed discohesive malignant cells. here we can see there are disc cohesive tumor cells. Normally they are tightly cohesive, but here we can appreciate that these are very loosely packed and very disc cohesive. There are no myoepithelial cells. Here we can also see some acini formation. On high power, that is 40x, we can appreciate nuclear pleomorphism. We can appreciate that these nuclei, they are actually of different sizes. Some are large, some are small, and they are having vesicular chromatin. And also, if you can appreciate in the image here, we can also appreciate these blue-colored prominent nucleoli, which are itself characteristic of malignancy. So on cytological examination, site 1, which was from right axilla, was inadequate for any opinion, and site 2, which was from left mammary region, showed features of a carcinoma. Further, a core biopsy. Yes, sir.
Who did site 1 FNAC? Was it done by surgeons or was it done by pathologists?
So DSA people who do FNAC and breast and lymph nodes.
So pathologist is not on site when these are done?
They are on site.
So how the sample was inadequate? If you have on-site pathologist and then you report after 14 days that the sample is inadequate.
Dipali, the problem is, don't try to hide what is right or what is wrong. This was done as a part of image-guided procedure where no JR from pathology or no SR from pathology was present. There are multiple causes for that. When the image-guided goes on, our JRs are not present because there are too few JRs to even go over there. Why are you saying this?
Okay.
Further, we received core biopsy from left mammary region on 13th May 2022, in which we received multiple grey-white linear cores, each measuring 0.6 centimeters in length, all embedded as A1, A2. So on microscopy, we appreciated these tumor cells. These are here. These tumor cells, they are present with large prominent nucleus with very pink eosinophilic abundant cytoplasm.
Why was biopsy repeated?
So this was the breast. That was from the axilla, first biopsy.
So the first biopsy was from the axilla.
But breast had no lesion?
No.
Answer.
PET CT was.
But the PET was done after this
Breast didn't
report.
have any lesion?
Clinically, there was no lesion palpable. But radiologically, on PET CT, there was some suspicion.
There was one
Please
nodule
answer.
shown.
I'll go.
I'm very sorry to come in inside what is supposed to be a student CPC. With that thing in mind, FNAC took place, again, axilla, and since breast was suggested, a breast FNA. Now, in the FNA what happened, the report was complementary to the initial core biopsy. What happened was, axilla was inadequate, but breast showed malignant cells. Combining these two, what came out was the most likely diagnosis came out to be breast carcinoma with axillary mets. As a result of which, the breast core biopsy was taken. And this breast core biopsy also showed malignancy. However, by that time, the IHC, on the IHC, ERPR HER2, even though ERPR on the axillary mets is not ideal. For HER2 it is sufficient, and yet it was ERPR negative. So that's that.
So the true-cut biopsy from the left breast showed features of invasive carcinoma, no specific type, with NRB grade 1. There are some few points about male breast cancer. The male breast is rudimentary organ composed predominantly of ducts, and it is located in the retroareolar region. Invasive carcinoma of male breast is a rare malignant epithelial tumor. Histologically, it is similar to the counterpart of its counterpart in the female breast. Male breast cancer accounts for less than 1% of all the breast cancers. In male, it generally affects the older age group, but can also affect the young and the adolescent boys. Klinefelter syndrome has an increased risk for male breast cancer. Males with hormonal imbalance, obesity, cryptorchidism, orchitis, testicular trauma, prostate cancer, and first-degree family member with history of breast cancer show an increased incidence of breast carcinoma. BRCA1 or 2 mutation carriers and other genetic alterations in CHEK2 and PALB2 are associated with male breast cancer. Pathogenesis of male breast cancer is not fully understood, but due to unopposed estrogen, there is enhanced proliferation of mammary epithelial cells leading to tumorigenesis. Generally presents as a unilateral painless mass in the subareolar region eccentric to the nipple. Patient may present with blood or serous discharge with a nodular mass which may involve the nipple. Invasive ductal carcinoma of no specific type is the most common type of the male breast cancer. Other special types like lobular, tubular, mucinous, metaplastic carcinomas are extremely rare. Most tumors are grade 2 on the NRB grading and are generally ERPR positive with frequent AR expression. Markers of breast epithelium such as GATA3, mammaglobin and GCDFP15 are commonly expressed and help in identifying metastasis from breast. In male patient with metastatic carcinoma, primary from prostate carcinoma should always be ruled out. The male breast cancers follows the same TNM classification as female breast cancer. Thank you.
So, rest of the routine investigations, including the CPC liver function test, RFTs and 2D echo were within normal limits. The PET and the histopath has already been discussed. So, finally, we made a diagnosis of metastatic carcinoma left breast, ER negative, PR negative, and HER2-3 positive with distant lymph nodes, skin and muscle involvement, clinically TX and 3M1. So, as far as management is concerned, we started the patient on chemotherapy along with HER2 targeted antibody therapy. We started him on HER2 targeted antibody, which is trastuzumab, with a loading dose of 8 mg per kg followed by 6 mg per kg, plus taxane, paclitaxel, and platinum, that is carboplatin, in June 2022. The chemo regime is usually Q21 days, and we started him on a chemotherapy doublet, that is platinum plus taxane combined, because of his symptoms, that is severe torticollis, skin involvement, which was affecting his day-to-day involvement, and due to his young age, it was more likely that he would have tolerated the doublet better. So after 4 cycles of systemic therapy, clinically the patient responded quite well. There was decrease in his skin thickening. I'll be showing the original latest images of the patient in the end. There was decrease in the skin thickening, torticollis, and his performance status was also improved. As far as toxicity is concerned, there was alopecia and CINV's chemo-induced nausea vomiting, which was symptomatically managed. And then, as part of the radiological examination, we repeated the PET scan in August. And as per the PERSIST criteria, the PET was suggestive of partial response. Hence, the same treatment plan was continued till October for a total number of 6 cycles. Although the patient was responding very well, but in view of some logistic difficulties, that is, our AIIMS packages are only valid for 6 cycles for a patient. So in view of that, we'll needed to change his therapy as the patient was non-affording. So another equally potent regime, that is capecitabine along with trastuzumab. Capecitabine 500 mg 3 times in the morning and 2 in the evening along with trastuzumab 300 mg was started. He was again tolerating the therapy very well, and one learning point is that trastuzumab is associated with cardiotoxicity. So every 3 months the patient needs to undergo echo for evaluation of his cardiac function, and this being a young patient, he was tolerating it very well, and the echo was always within normal limits. Again, as part of the routine workup, we did a radiological assessment in January. Again, it was suggestive of stable disease. The same regimen was again continued for a total number of 13 cycles. The patient maintained like this till May 2023. Although clinically he was stable, but radiological assessment, that is a repeat PET scan of the 23 May, was suggestive of progressive disease. Again, in view of the good performance status of the patient, young age, he was shifted to a doublet of gemcitabine and carboplatin, along with the HER2 targeted antibody therapy, which is trastuzumab. As of the last follow-up in August 2023, which is last month only, the patient is doing quite well. His skin thickness has improved. So this is the image of the patient only. So the changes in the skin, like these were present all over his skin from here to below. But as you can see, they have just only a minimal part is left, so indicating that the therapy has worked quite well in the patient. So the further plan is to continue the same for further 6 cycles, and further plan will depend upon his tolerance and the response assessment as done. Although a bit of discussion has been done by my pathology colleague, I'll slightly deal with the carcinoma and cuirassier part. It is an uncommon presentation of the metastatic cutaneous carcinoma, most often derived from a breast carcinoma. Less commonly, carcinoma and cuirassier can also come from the stomach, kidney or lungs and deposit to the skin. In breast cancer, the incidence is approximately 6%. And the rare part is that it usually tends to appear after the initial treatment or the surgery, and obviously it is most commonly associated with women. But in this case, the patient was male and he hadn't undergone any treatment, so it was an upfront presentation. It first appears as nodules at coleus forming diffuse sclerodermite indurations invading the chest wall and abdomen, and basically the carcinomatous lymphatics result in the extensive thickening and fibrosis of the dermis and subcutis of the chest wall. Male breast cancer is in itself quite rare. That is, for approximately 120 female breast cancer cases, there are just 1 or 2 male breast cancer cases. And in the female breast cancer also, HER2 positivity is quite rare amongst the ER and PR and the triple negative, only 20% in females. And in males, out of those rare cases, again the HER2 positivity is only seen in 9%. Again, telling the rarity of this case. Just an image from the MEGM of carcinoma and cuirassier patient. So management options for the metastatic HER2 positive breast cancer include trastuzumab, pertuzumab and taxane. But as pertuzumab is not accommodated in the Ayushman packages and our patients generally can't afford, so we aren't able to offer. And some other newer antibody drug conjugates including trastuzumab deruxtecan and adotrastuzumab emtansine are also, again, the affordability issues are there. And if the patient can't afford, then we can even start the patient on single agent trastuzumab. Nowadays, some oral therapies of the HER2 inhibitors are also starting, like tucatinib, capecitabine as I already told, and trastuzumab. Lapatinib is also a newer anti-HER2 agent which is oral. And importantly, tucatinib has also shown activity in the patients with brain metastasis. And other combinations include lapatinib, neratinib, capecitabine, margetuximab. So the basic take-home message is that carcinoma and cuirassier needs to be differentiated from the non-oncological causes of skin thickening. Importantly, detailed history, physical examination and appropriate radiological investigations will help in the diagnosis of the same. And yeah, neoplastic etiology, although rare in the young, can always be kept in the differential if the history and physical examination suggests the same. As in this case, the patient had a history of weight loss and loss of appetite, along with the characteristic examination lymph node findings of the consistency and the hard nodes. These are the references. Thank you.